Hello again, this is Amy Vassarino at OPCA, and this is our second training module for Care Steps. This is about the delivery, documentation, and designing of Care Steps. And with me again, I have Charles Issue.
Hi, everyone.
All right, let's take a look at today's agenda. As you can see that we're going to start with context setting, and really that's just being clear about who the target audience is for this webinar module. And then Charles is going to help us with the what, who, and how of Care Steps. And he's going to finish by giving some real-world examples from his organization, Virginia Garcia. And then I will close out the webinar by talking about training strategies. So let's go ahead and get started. Like I said, this is the second training module of 3, and we are doing the jump straight in. So we already assume that you've seen that first one that covered the overview and the accountability of Care Steps. And this module is really targeted toward patient-facing staff members at your organization, those that might be actually delivering and documenting the Care Steps. So let's go ahead and look at the same slide that we saw in the first module. Once again, this is the 18 Care Step categories put into 4 buckets. New visit types, coordination and integration, education, wellness, and health promotion, and reducing barriers to health. I'm going to go through them one by one, and then I'm going to have Charles just pull a few out to talk about that he feels he has more to say about. I'm just going to be reading them. So within the new visit types bucket, we have online portal engagement, health and wellness call, home visit billable encounter, home visit non-billable encounter, and advanced technology interactions. That's the new visit types. Then within coordination and integration, we have coordinating care, clinical follow-up and transitions in care settings, coordinating care dental, behavioral health and functional ability screenings, and warm handoffs. All right, moving to the next bucket, the education, wellness, and health promotion. We have care gap outreach, education provided in group setting, exercise class participant, support group participant, and health education supportive counseling. And then finally, reducing barriers to health bucket, we have social determinants of health screening, case management, accessing community resources and services, and transportation assistance. So Charles, which of these would you like to speak a little bit more about?
Yeah, thank you, Amy. There's so much behind each of these categories as you're starting to learn and in reviewing the actual document. I'd like to just spend a little time to talk about one category in each of the buckets. So for new visit types, we're actually leaning on advanced technology interactions quite a lot these days, especially with the pandemic going on. This is where all our telemedicine encounters are dropping into. There's been quite an uptick in that activity at Virginia Garcia. It's so interesting because this category has been on the back burner for us for so long, and here it is all of a sudden being so useful to us. So really thankful for that category, and I think it's something you're going to find really useful. It's not called telemedicine because there are other advanced technology interactions that can fall under that core category, like remote patient monitoring, if you have that kind of system set up with some of your patients. And if you do any kind of texting with your patients, that's something that could also fall into this category as well. For coordination and integration, I'm definitely going to highlight the coordinating care, clinical follow-up, and transitions to care settings. This is a real emerging program across FQHCs. It's a big part of our value proposition as a site in allowing us to partner with hospitals and payers and figuring out how to bring down the total cost of care, by helping patients to transition out of that hospital setting more smoothly and reintegrating them into their primary care home. What's so exciting about that category is that there's so many different staff roles that can plug into that category, which I will be highlighting later on in this webinar. I want to extract health education supportive counseling out of that bucket for a bit. That is a really nice broad category. In my mind, that really represents all the non-billable face-to-face visits that could occur within a health setting. When I think of this category, I think of our dietitian, talking to patients about healthy eating patterns. I think about our CHW meeting with patients, to go over some housing options to help connect them to food, if that's a need. And I see this as the counterpart to the health and wellness call setting category. That category represents a lot of the non-billable care calls that occur within a health setting. Health education, supportive counseling represents a lot of those therapeutic interactions that are occurring with care team members and the patient in a face-to-face setting. The last category, the last bucket, reducing barriers to health, is a very important one. From here, I'm going to focus on, of course, social determinants of health screenings. It's so refreshing to see SDH screenings being a category on its own. It's still an emerging practice for many of us. It's something that we're trying to figure out how to do, how to operationalize, how to scale across the health system. I think we've all gotten really good at doing this in small settings. But this category ensures that there is something in place for if and when we are able to do this on behalf of all our patients, or if we just need to attach the screening to any population we want to learn more about while we continue to think of care delivery design for them. So that's a little deep dive in 4 of the categories. So much exciting information that could be shared on all 18. But if you have any questions, save it for the Q&A, which will be coming in August.
Excellent. Thanks, Charles. And just to let everybody know that all of these are laid out in detail in the PDF that we will be sending along with these modules, that they actually go into the definition and use of each of the 18 categories. So if you want to know more, that's another good place to find out. All right, let's go ahead and move on. I am going to actually hand this is more of the continuing of the what, so I'm going to hand this back to Charles again.
Yeah, so what are care steps? I think, assuming that you're still, on the path to learning about these care steps, you may have learned about them months ago, or you may have just started to learn about them during this call, which is perfectly reasonable. So care steps, it's simply a way to document and to report the work of your entire care team. It's not just about reporting the work of the provider, it's about reporting that patient-facing work of your MA, of your patient care coordinator, it could be the work of your RN, of course. It's also a way to optimize care team access for your patients. So in other words, this care steps incentivize you to think of other ways to provide access for patients. It can be telemedicine, which, as we talked about, is a big deal these days, or it can be any one of those, care steps that Amy listed off. Under APCM, any one of those are access points that any one of you could provide for your patients, assuming you're working within the realms of your license, of course. I also think of care steps as a key way to address health disparities. The APCM allows us to really move away from this one-size-fits-all care team model in that there are care steps now, and care steps gives you so many different options for providing care and access to all the different patients you serve. And finally, care steps, since you're getting paid a capitation for your patients, it provides you an incentive to think about totally new service delivery models. So to begin with, you're going to want to start focusing on capturing the care steps that you're already doing, that you've been doing for probably many years now. once you get used to documenting that work, you're going to start turning your attention towards creating new care models that can also qualify as care steps. And thinking more strategically about, okay, how can we improve the care experience for our patients? How can we improve our outcomes? And how can these care steps help us get there? So, who provides care steps? It's actually quite a critical question, because one care step from two different roles could totally change the experience of that care step. This is a multidimensional thing we're talking about here. So who provides care steps? This is a really important question, because one category could be provided by multiple different people. And each of those roles can really change the way that care step happens. So now we're going to go through some of those roles, and I'm going to talk about the different care steps those roles can do. So the example you're going to see, this is more or less my interpretation, based on my experience, not only at OPCA, but more recently at Virginia Garcia, on the different roles and what kind of care steps they can perform. Of course, this is going to vary according to the roles you have in your health center, and based on how you want to implement those care steps as well. So don't take this as something that's set in stone. Just take it as some guidance and suggestions as you think about your care step strategy and implementation plan. So when thinking about care steps, I always want to start with the 3, 2, 1. When thinking about care steps and the people that provide them, I always start with the core care team. And for Virginia Garcia, that core care team includes a provider, an MA, a care team panel care coordinator, a referral coordinator. We also connect a front office receptionist to that team, and the care team always has 1 or 2 RNs. So providers, in my mind, they are actually any of the care steps that they provide that are in lieu of office visits are generally those MyChart messages where patients can directly access them between visits. And as mentioned, those telemedicine encounters. So as you see there, the care step category would be advanced technology interaction as well as online portal engagement. The MAs do a lot of care gap outreach. They're always participating in panel scrubs, seeing which patients are due for what, and they're outreaching to those patients and trying to get them in on time. So that is a very pivotal care step that is generally provided by our MA. The care team panel care coordinator also supports them in doing that work. They can also help the patient with transportation assistance if they're having difficulty getting to their appointment or to any other appointment within the health system. Transportation assistance could also be provided by a referral coordinator. But for this activity, I just wanted to highlight how they help with coordinating care outside of the clinic. So dental is another service that we provide at Virginia Garcia. So our referral coordinators are also always helping patients in accessing dental care as well. So that's a care step they provide quite regularly. We do not have our front office receptionist providing care steps, although depending on the type of receptionist you have, you may be able to employ them in providing that service. But for us, this is primarily an administrative role, and we wanted to delineate administrative calls between care calls, which in my mind are more aligned with the care step list. Our care team RN is always on the phone for most part of the day, so they are actively engaged in health and wellness calls, whether it's a triage call, whether it's a broad care call that they want to have with the patient, or even if it's a prescription refill. that a patient wants to have coordinated without needing to come in for a visit. They also provide quite a lot of case management, which is a very critical care step, especially as we look at more complex populations. So I think that is a very, very key category for our RNs to take the lead on. I'm not going to go over the workflow or one column. I take this as a suggestion for you to consider when building your own documentation map. So at Virginia Garcia, we decided to focus on these workflow options for these care steps. And I also wanted to be a little more prescriptive as to when that care step could happen, just so the care team member isn't so befuddled and confused about what to document and when.
Thanks so much, Charles. One quick question.
Yes.
We'll be talking a little bit about the auto capture and the touch list. Do you mind just saying a few words about the reason for call workflow?
The reason for call category is a very important one because so many care steps occur over the phone. We wanted to make sure that there was a place within the telephone counter that a care step could be counted or documented, I should say. So if there are people that don't want to go through the touches list, which would require an extra step, the reason for call is what we would say is where the work is happening within the phone call. And it's just another way to document that care step.
Great, thanks.
So what's very exciting about care steps, it's not just about capturing the work of your core team, it's also an opportunity to capture the work of your expanded team. So the expanded team, it can be a transitions of care panel care coordinator, someone that's really focusing on those transitions between hospital settings and the primary care team. It could entail your clinical pharmacist, who can be part of that transitions of care team. It can also, of course, entail your behavioral health consultant. If assuming you're doing a BH integration, the warm handoffs, those behavioral health and functional ability screenings are care steps that they would usually document. It could also include your social workers that are leading support group participant classes that for your patients, or any of the home visits that they do, knowing that some patients do require that extra level of support from the care team. And you can also have other roles that are not always directly linked to the care team. They could be, but for Virginia Garcia, these are what I consider upstream care team roles that work on behalf of the clinic and are focusing on specific populations at different points of time. So the PCAL is also someone that's really heavily involved in care steps. They are usually working with helping patients access community resources and services. They're also heavily involved in helping patients get transportation assistance. Our PCALs are always figuring out ways to give patients bus passes. They help arrange Uber rides for them if necessary. They're also on the front line of doing those social determinants of health screenings to figure out in a systematic way what are the barriers of our patients, just so that information could get back to the care team while they figure out how to meet their need in that moment. Dietitians, we have dietitians at Virginia Garcia. They have group classes. Of course, that's a care step opportunity, as well as face-to-face visits where they're giving healthy eating advice and support in classes. Social worker can also be considered an upstream care team role. I also like to highlight our Zumba instructors. Zumba instructors, our teaching kitchen instructors, exercise class instructors that are housed in our wellness center. They're also providing care steps. Anytime a patient accesses those classes, they're doing a care step that's counted for APCM. I also think of program specialists who I just mentioned. So a program specialist could be teaching a teaching kitchen class, and they could be doing.
Thanks so much, Charles, for walking us through the potential staff members that could be delivering care steps. It's so nice to see things mapped out according to how things work at Virginia Garcia. All right, next we're going to talk a little bit about the how, and Charles referenced this a little bit in his tables where it showed the different workflows. There are two different ways that care steps are documented: steps that are considered automatic and care steps that will be considered manual, that you will actually need to document within your EHR. In OCH and EPIC, I have listed those on the next slide for you so you can see which ones are automatic and which ones are manual. It's important to know which ones are which so that your care team members will be able to follow those couple other clicks they'll need to document the manual care steps within the EHR. We still call the touch tab, as I mentioned, and as Charles mentioned, and it will require a couple of additional steps. The automatic ones do not. If you are building your own system, then we recommend that you automate as many of these as possible. We have seen much better results in health centers who have set up their systems to be this way, where it requires very little extra effort from their care team members, and they've seen just a higher number of care steps documented for that reason. So let's go ahead and take a look at the EPIC map, and you can see the care steps list on the far left, and then it shows you which ones are auto-pulled and then which ones are from the touch tab. And I think you really want to look at the two right columns. According to this graph, which might be a little bit outdated, but not too much, I don't think they've made many recent changes. 5 are auto-pulled and the rest would be manual, and that means that your care team members will need to go into that touches tab, do a couple extra clicks until they know that they've gotten credit for delivering and documenting that care step. The touches tab, again, this is an old, you'll see that this from 2016. I'm pretty certain that it still looks like this within OCHIN, but you'll see that it just has a couple of other clicks. You'll need to go into patient touches, and you'll need to actually select the category that you want to document. Charles, what other tips do you have for documentation?
Yeah, I have quite a few, and this is especially geared towards those clinics that aren't part of OCHIN. As your documentation platform is getting built, these are some things for you to consider. You definitely want to start distinguishing between those categories that are going to be documented manually versus those that will be automatically captured. I think, as Amy said, automating as many of those as possible will help kind of get the distractions of documentation out of the way and allow you to focus on care, which is all you want to do anyway. I also think you want to establish workflows that fully capture all the care steps that can occur over the phone, knowing that a big body of our work happens telephonically, as well as the care steps that happen in person, and any other care steps that happen through other means of technology, such as texting, remote patient monitoring, etc. I also think it's important to make sure that you're able to distinguish between billable care steps that are generally tracked in an automated format and those non-billable encounter types. And to the best of your ability, try to align documentation with where the work is happening. This was a very strong guiding principle for phase 1 as we were developing the care steps. No one wanted to go away from where the work is happening. It's usually within a telephone encounter, an interim note encounter, and I strongly encourage you to keep documentation aligned with where you generally like to do your work. always want to ensure that engagement with the patient happened before you document that care step. It's easy to come up with scenarios that may feel like care steps, but if that engagement didn't occur and if the criteria wasn't met, you can't document the care step. So really being clear about your care step terminology that's used on site and what really qualifies before you can press that document key in order for it to count. So this is just a high-level capturing of some of the documentation tips. During our Q&A session, I would like to talk about more specific workflows for you to consider as you think about the different ways you'd like to document your care steps. Just some additional insights to consider when thinking about implementing and socializing documentation. And this really helped a lot of our non-OHIN clinics over the years, and I still think it rings true today. I wouldn't focus on trying to capture all 18 of them from the get-go. You'll really feel like a deer caught in the headlights there. I would just focus on adopting several of the low-hanging fruit categories, those categories that you're already doing, that could be easy to document, and start championing the documentation of those categories. It could be over the first 3 months, first 6 months, or that can be your focus area for a year, assuming the state's okay with that. And then from there, you can build towards adopting all 18 categories. I would create a culture around this. It's not just within the EHR, but within the care team room. What kind of reminders are you putting up there for to prompt you to document a care step? How often are you talking about care steps at your team meetings? Are you creating some fun games around care step documentation? Are there competitions at play? I think these are things that Amy will touch on, but I just want to emphasize it's really important for you to reinforce these practices, especially since they're new ones. As I highlighted, each care step is different based on the role that's providing it, or any given care step is different based on the role providing it. So maybe you want to just tackle this through a role perspective. Maybe providers should focus on these 2 roles, while MAs should only focus on this role as a start. So you wouldn't worry so much about the categories, but just worrying about the roles, taking care of what's in front of them and what makes sense for them as you initiate this program.
Awesome, thanks so much. And now I think we want to talk about a real world example at VG. So I'm going to hand it back to you again.
Thank you, Amy. I am going to talk about 2 examples at VG. And these are examples where I felt like we were really living the care step dream. So what you see in front of you is a trend line of our face-to-face telemed visit ratio since January of this year. So as you can see, January, really the first week of January, we provided 1% of telemed visits. 99% of our visits were conducted face-to-face. 3, 2, 1. So I'd like to share an example of how telemedicine has gone really well for us, since this pandemic started. In the beginning of the year, we were only offering about 1% of telemed visits to our patients. And once the pandemic happened, that sharply increased to about 80%. I'm excited to say it only took us 1 week to get to 80%. And since then, we've been trending between the 65 to 80% level. And that's reflective of us kind of figuring out how to open things up again and bringing people back in a safe manner. So I think a lot of us health centers have figured out how to get to telemedicine. What's exciting at VG is that we knew we can go there without risking our payment. without jeopardizing our financial model. And because care steps have been socialized within our organization for so long, we felt like it was easy to turn this switch on since the capability was already there. So what's impressive is not that we were at an 80% level, it's that it took us so few days to get there. And we were ready to be there, and we had such peace of mind knowing that we were getting paid to do that kind of work. The next example I want to share is about our Transitions of Care program. So Transitions of Care, this was a program that was grant funded initially, and it gave us an opportunity to figure out ways to transition patients that were admitted to the hospital back within their care team. And there are so many care step opportunities within this program. Opportunities that include the clinical pharmacist, that include the RN, but most importantly, has started to include the Transitions of Care patient care coordinator. That role is mobilized to check in with that patient between visits, check in with that patient even if they decide not to enroll in the Transitions of Care program, which is very visit intensive program with any one of our providers. But the role of this, or the job of this role is to track that patient, to meticulously connect with them until they feel like they have all their post-discharge needs met. And it took us about a year or two to figure out the rub with that role. And I'm actually excited to say that the grant funding has ended, and because of APCM, we have been able to retain that role and to make it part of our normal operating model. So now that we figured out the value of this Transitions of Care patient care coordinator role, I was confident in presenting it to our executive team in showing how this role is adding value in a way that's distinct from our normal care model, and it allowed us to continue this program without grant dollars. I want to talk a little bit so this is where we get into the realm of designing care steps. So grant funding gave us this program, and we were very mindful of that care step category, Transitions of Care within clinical settings. So if you go to the next slide, you're going to see how we use this business model canvas in order to figure out what this care step can look like moving forward. So again, we use this business model canvas to help us transition from a grant-funded program into something that is now part of our core business model. And on another slide, or maybe during the Q&A, I'd be so happy to dive into this canvas with you. But what I really want to highlight is that to start, yes, care steps is about documenting your current work, but it also gives you an opportunity to think about the business models that you want to design for all the different segments you serve. And in this case, it was about designing a model that made sense for our highly complex, high utilizer patients. So going to the next slide. So we took the business model, and with it, we mapped out exactly who this patient segment is, what the care step is, which is highlighted in the value proposition. And we got really specific about the type of relationship we want to have with those patients. So in the Transitions of Care program case, it's about having a really intense concierge type relationship with them. We clarified channels, which is where you have a whole nother list of care steps. So it could be through my chart, it can be through care calls, or it can be through face-to-face visits with the RN. And then once we highlighted all those care step opportunities along with the value proposition, we listed out the key resources that are needed in order to sustain that program. So it's not just the transitions of care team, but it would also entail like administrative overhead, as well as any other costs that you're going to need to sustain moving forward. And then what's exciting is that I was able to include some care step revenue in justifying the cost of this program. So I was able to highlight the cost structure, but I was also able to highlight some of the revenue that would be coming in to support this program now that it won't be grant funded anymore. So this is an example of how we took a tool to integrate a care step into our normal operating model. And I know it may feel daunting at first, but once and if you're ready to think about the future state care steps, I'd be happy to talk about this tool with you. And maybe we can bring it to our Q&A session.
That would be great, Charles. And maybe if there's a template that we can bring for them to then use on their own to build this sort of tool, that would be excellent too. All right, I'm going to close this out by giving a couple of ideas for training your staff members. And when we make these modules available, we'll also be having these documents along with them. So the first one is the Care Steps Gallery. It is a PDF that has each page its own care step, which is the definition and use, and a picture that goes along with it. And the ideas that we have for you are to either share this PDF through email to all staff members so that they all have that document available on their own computers, or to print it. And then if you print it, you can either hang the individual care steps on the wall by team members to routinely deliver and document those individual care steps, or just put them, the entire document, keep them on a key ring, and keep copies at each workstation so they're also available in hard copy there. In the past, as Charles mentioned, we have had teams at health centers use these for competitions where they would use these, learn from them, and then compete with each other about who could actually document the larger amount of care steps within the health center. And there were prizes. There were sweatshirts, I think, and I don't know, some other treats. So it's something to keep in mind. Everyone loves a little bit of healthy competition. So that's one way that you could do that. The other document that we'll be sending along is, I know that those who've been on the onboarding process have been playing this game. It's called Name That Care Step. And what I'll be providing you is a whole deck of pre-made slides with scenarios typed in to get you started. And then that slide deck can be used for trainings within your staff team, like maybe a full staff meeting, or it can just be a fun start to other meetings as well, sort of as an icebreaker, which is how we've used it. It's fun because it can be tailored to fit different scenarios. So if your health center is likely to be focusing on a subset of care steps, you can tailor that deck to focus on those particular care steps. The way that I've done them as part of the onboarding process is to start with pictures and then have those accompanying stories or scenarios. But you can also turn it around, and in the more advanced version of this, you actually have the name of the care step category on the screen, and then you have to sort of pull out what that could look like at your own health center. So staff members have to think about it the sort of opposite way. So those are the two ideas I have for you as you think about how to spread this information amongst your staff team members. So that brings us to the end of this second module. We will be producing one more, which will be more toward data and QI staff. If this is your last one, we thank you for your time. Thank you for making the time, and we look forward to meeting with you at the Q&A session that will happen in August. Thank you, Charles.
Thank you, everyone.